So it's a pleasure to be here talking about malaria control in Papua New Guinea with a particular focus on community engagement, uptake and access. So as James mentioned, PNG has traditionally had the highest malaria endemicity in the Southwest Pacific region and the highest P-Vivax burden of anywhere in the world. It also exhibits a particularly complex malaria epidemiology with 4 Plasmodium species, 13 overlapping vector species, and a really diverse environmental health system factors that combine to give really heterogeneous transmission disease burden across the country, and has traditionally meant that malaria control and the idea of elimination has been fairly hard to grasp for PNG. This has been demonstrated throughout the history of malaria control in PNG. PNG was part of the Global Eradication Program of the 1960s and 70s, and a very strong program of indoor residual spraying and mass drug administration with chloroquine really did have a big impact on successfully reducing the prevalence of malaria to less than 1% overall. However, critically, a loss of community support, particularly around a failure to really sensitise communities to the use of DDT, the risks and the benefits, meant that the program really lost the ability to continue, and eventually political and financial will waned. And almost immediately, malaria resurged to pre-intervention levels. There was a shift to Plasmodium falciparum predominance, and then alongside increasing resistance, also observed in other areas, to chloroquine and amidiaquine, the program really ceased. And it wasn't until the early 2000s that insecticide-treated nets became the principal vector control intervention in PNG. And then in 2004, the Health Department was able to gain global fund support to really expand and strengthen their national malaria control program, which mostly relied upon the free nationwide distribution of long-lasting insecticide-treated nets from 2005. And then in 2012, a switch to rapid diagnostic test confirmation of infection prior to treatment, and a switch to artemether lumefantrine as first-line treatment for uncomplicated malaria, and IPTP with sulfadoxine pyrimethamine. And this suite of interventions has really had a dramatic impact on malaria across PNG, with a demonstrable decline in under 5 mortality, a sharp decrease in parasite prevalence from 17% to less than 2% in children 1 to 5 years of age, and declining incidence of clinical malaria at health facilities around the country. However, it's important to note, as shown in the graph on the right, that this hasn't been uniform in all areas of the country. It was very swift in highland marginal zones such as Karamui, and the decline was slower in coastal and island regions. And in some areas such as Madang, that trend has even started to reverse. It's also important to note that these curves, the data in these curves, also mask the very vast asymptomatic and submicroscopic reservoir of infections that continues to exist in PNG. And when we do look at this in more detailed cross-sectional surveys using sensitive molecular methods, we can see that even at the sort of height of control, if we like, when prevalence by light microscopy reached that level of 1 to 2% in 2 regions of the country, the prevalence by PCR was still 10 to 15%, and the most recent data from Madang province from December, January, really indicates that this has started to resurge back up to 30-40% prevalence by PCR, highlighting the variability in transmission and transmission potential that still exists in PNG, despite a fairly uniform rollout of interventions, which is now what I'll spend the rest of the time talking about, is how those interventions have been delivered and the community engagement process, uptake and access to those interventions, and how that's impacted the success of the program. So the scale-up of long-lasting insecticide-treated nets through nationwide mass distribution program has really been the mainstay of the program since 2005. This was coordinated through Rotarians Against Malaria in conjunction with the National Department of Health and financed by Global Fund. And since 2004, over 10 million LLINs have been distributed to households, pregnant women and children under 5 years of age. This has been done through an NGO and community-driven model of implementation, And it's important to note that 90% of these 10 million nets have been delivered to the household level. And as these photos show, many of these areas are the most difficult to reach places in PNG, and it has relied upon an incredibly close partnership with communities to ensure that this level of coverage and that all districts in all provinces have been reached by this distribution campaign. The aim of the program was to achieve 80% ownership and 80% usage. And formal monitoring and evaluation of the program conducted by PNG-IMR over the last 8 years has shown substantial gains in LLAN uptake. If you look at the ownership of long-lasting, so this is permethrin impregnated nets, prior to the scale-up, this was only 10% of people who owned such a net. And in 2011, this reached 82%. Of the population. However, there has been somewhat stagnant progress since 2011, and the uptake of ownership of 1 LLAN per 2 people is still below the target of the control program, suggesting that the distribution model really may still not be reaching some areas, or more likely that with some reductions in transmission, people need some continued education around the benefits of still owning and using a bed net. When we interrogate this more with the usage data, we do see that the LLAN use levels really reflect a current willingness to use rather than poor access, with only 54% of respondents reporting to have slept under a net on the previous night. And although one might expect that in our high-risk group of children under 5 and pregnant women that usage might be higher, we actually see that this is still only at 50 to 60%. Again, highlighting that much of the education and behaviour change communication that occurred during the initial scale-up of the program in PNG really needs to be a continued focus of the LLAN distribution, but due to funding constraints, this hasn't been occurring with recent rounds, but I think to get more uptake and usage, more benefit out of LLANs, this is essential. Additional barriers and enablers to further gains via LLANs include the inability for the program to sustain financing of universal nationwide LLAN distribution. So as of now and going forward, highland regions won't be receiving LLANs at all, and many fringe areas will only be receiving targeted under 5 distribution campaigns. There's also discussion that there's really potential for the same model, now that we've had this distribution model going for 3 or 4 cycles, potential for this model of distribution to target and miss the same communities. And that's something that people are hoping to address. We also have evidence that there's community reluctance to use LLANs in North Coast and Island areas, which are the most hot and humid areas of PNG, but they're also the areas with the highest malaria transmission potential. Moreover, the timing of LLAN use, when people actually go underneath their bed net to sleep, has really been shown to decrease the protective efficacy of nets, in that people are really only being protected for probably 3 of the 8 hours that they're at risk during a night. And alongside the increasing predominance of outdoor biting vectors in many areas of PNG, this is a real barrier to further gains via LLANs. There's also the potential for insecticide resistance to emerge, as James mentioned. Recent monitoring conducted in 2006 showed that PNG vectors are still fully susceptible to the permanets in use in PNG, but continued monitoring is essential given the country is currently solely reliant on LLANs for vector control. Possible enablers include further behaviour change communication conducted with LLAN distribution. I think this could really strengthen the impact by providing evidence that the nets are still working. I think this is one thing that communities require, is demonstration that the tools they're being given are still effective at solving their problem, and appropriate use by all target groups. The feasibility of social marketing of LLANs, particularly in urban and peri-urban areas, is being explored, alongside social media activism as well. So the other key intervention has been improved diagnosis and effective treatment. So in late 2011, early 2012, the National Malaria treatment protocol changed from one of presumptive treatment, where, as you can see from these curves, 80 to 100% of fever patients received antimalarials upon presentation to a health facility. So as of 2012, this changed, and we can really see from these repeated health facility surveys that have been conducted over the last decade that now we see in 2016 that 80% of fever patients presenting to health facilities are tested using either a rapid diagnostic test or microscopy, and that there's been an increasing proportion of these cases being treated according to the prescription guidelines, but this still does sit at only 60%, so there's certainly room for further improvement. Qualitative evidence suggests that there's still a lack of confidence amongst health workers on how to treat RDT negative individuals, as well as considerable community pressure to treat. I think it's important to remember that stock-out issues occur in PNG, and sometimes when families have walked quite some hours or distance to get to a health centre, being told that the RDT is negative is not really sufficient evidence for not receiving an antimalarial if the health centre has one, and health workers find this to be a continual problem. They also express a lack of confidence to prescribe Primaquine for P. vivax and mixed infections in the absence of G6PD testing, and also just through poor education and training around the interpretation of RDTs for vivax malaria. The data from health facility surveys has also shown that the number of health workers trained really peaked in 2011 and hasn't changed much since or declined. There's been limited training and retraining opportunities in case management and limited or no regular supervision. This is something that we're currently addressing with some new funding from DFAT and the Chinese government to actually really present evidence to health workers on the efficacy of RDTs and ACTs that they're using to try and ensure compliance with the treatment protocol. But certainly treatment counselling practice is also often poor, which may contribute to poor patient compliance with the 3-day regime of artemether lumefantrine, but certainly poor compliance with the 14-day regime of Primaquine, which almost never occurs. As I mentioned, stockouts have been a problem, particularly over the last 2 to 3 years. And the health facility survey data shows that the proportion of health facilities with MRDTs and AL in stock really peaked in 2014 and has subsequently declined, confirming that continuity of supply has been a real issue. And I think obviously this is a problem in that parasites aren't being quickly and effectively treated, but moreover, I think this is a huge problem in that it generates a lack of confidence in the community, in their own health system, and in the malaria control program. And this really has negative flow-on effects to treatment-seeking behaviour and the overall community engagement in the malaria control program. Looking at treatment seeking, we can see that health facility access remains poor, with less than half of all recent fever episodes brought to a health facility, and 35 to 40% of aid posts are out of operation at any one time. And it should be noted that in rural areas of the country, it's really aid posts that provide the service to most of the population. These smaller and more remote aid posts are less likely to have RDTs and antimalarials compared to your larger health centres. We also see in the recent health facility survey data that the median waiting time, so that's the time from the appearance of first symptoms to when I go to a health facility for treatment, has actually doubled from 24 hours in 2010 and 14 to 48 hours in 2016. Now, this requires further investigation. It could obviously represent two things. It could be that individuals are actually having to seek treatment further from home. It's taking them longer to go through that process. It could also be that with declining transmission, there's a greater ambivalence in terms of whether or not they really need to seek treatment for that fever. But certainly this data supports further investment in behaviour change communication on the importance of early diagnosis and effective treatment, and it also supports the scale-up of home-based malaria management programs. This has been an important component of the program in PNG, and HMM substantially improves access to prompt and effective treatment of simple malaria. It relies upon a network of community-based distributors that live in some of the most rural areas of PNG. And in PNG, this has been rolled out in 3 provinces, in Sundown Province by PSI, in East Sepik Province by Save the Children, and in East New Britain Province by the Burnett Institute. And since 2012, over 2,500 CBDs have been trained in the diagnosis and treatment of simple, uncomplicated malaria, and the program has expanded to cover a population of more than 500,000 people in high-risk areas. Evaluation of that program has shown that seeking treatment from a CBD is regarded to be the first choice of caregivers, especially in the most remote areas such as Sundown Province, and that this program really does encourage treatment seeking and close community engagement with the program. However, scale up of this in PNG is really hindered by the overall state of the health system infrastructure and the support that it could provide to volunteers in their area in terms of supervision and provision of sufficient supplies. Very quickly, building on what Archie said, I think it's really important that surveillance becomes more linked in to community engagement. At the moment in PNG, this really doesn't occur at all. We have a very good, thorough PNG National Health Information System that's been operating for the past decade, with very detailed outpatient and inpatient records of cases and deaths from health centres and hospitals. However, this doesn't include aid post data, which again, it represents a huge proportion of where people seek treatment. And it's also not put together in a timely enough fashion to allow any sort of surveillance response type intervention. The Global Fund supported M&E that the IMR has been undertaking over the past 8 years has really been essential in providing critical data on the impact of the program through national household surveys conducted 4 times, through morbidity, demographic health and mosquito vector surveillance at sentinel sites, as well as through therapeutic efficacy monitoring of the first and second line antimalarials in the country. However, again, despite good dissemination of these research findings at the national level, there hasn't been the funding or commitment to translate this into good education, material and behaviour change communication to get this information back to communities so that they are aware that the nets that they're still being given are effective against local vector populations, that the drugs they're taking are still effective, and that it is still important, despite the fact they may be seeing lower transmission, to own a net, to use a net, and to promptly seek health treatment when they have a fever. Very quickly, pilot Global Fund and Asian Development Bank supported electronic health information systems are starting to be piloted in PNG. They're operating in 4 provinces since 2014, and they're really showing some very promising results to overcome this issue. They combine outpatient and inpatient malaria case data with geographic information and mapping software, giving real-time actionable information, and I think it will be really interesting to see how and when this can be scaled up in PNG. In December and January, a revision to the National Malaria Control Program strategic plan was undertaken, extending it from 2018 to 2020. And this really is a strong plan that provides a powerful tool for advocacy and for leveraging additional funding for the program to really achieve the overall goal, which I can't read still, which is to sustain the gains and accelerate the reduction of malaria burden in PNG through the objectives laid out there. Importantly, the final objective is a new one because in 2014 the PNG government did commit to the regional target of achieving elimination by 2030. And so despite the considerable challenges that I've highlighted throughout this talk, it is expected that the next iteration of this plan will include a clear objective of accelerating towards elimination in PNG between 2020 and 2030. However, I think it's important to note that despite this political will, the financial ability to do so is quite limited. If we look now at the situation that we have going forward with reduced Global Fund support, as well as a fairly constrained PNG government budget, we're actually looking at a program that has substantial gaps in funding, We're unable to maintain universal net coverage. We're unable to maintain what is actually in the plan in terms of diagnostics and treatment. Notably for this talk, there's absolutely no funding allocated towards behaviour change communication or community engagement at the moment. So I think it's a really critical point at which the program, requires additional support in order to sustain the gains that have been made and develop a case for accelerating towards elimination. So just to summarise, it's been a remarkable achievement to date, but sustainability is a problem. LLAN distribution remains the priority, and it will take the majority of the funding that is being allocated to the program in order to maintain reductions and ensure continued progress. Improved messaging and behaviour change communication is essential. Access to treatment remains very low, and there are significant operational challenges that need to be addressed in the future. Health system strengthening, HMM models offer considerable promise for PNG, but they do require oversight by a functioning health system. Ongoing monitoring and surveillance is critical, especially in light of the changes to the distribution strategies. Seeing how that will affect transmission in the Highlands regions is essential. And a more robust surveillance system that includes a geographical component is vital for improved reporting from aid posts and village-based volunteers as well. And I think, again, as the photos demonstrate, communities in PNG are the backbone of any successful health program. And without investing in strategies of community engagement and really educating people on why it's important to remain engaged in this program, I think we won't achieve the gains that we want to. So to briefly acknowledge a lot of people, I won't go through them, but especially my colleagues at the Department of Health in PNG, and Manuel Hetzel, Justin Pulford, and Tim Freeman, who've really supported all of this work. Thanks very much.